evening, everyone. Thank you for coming. Welcome to our Heal at Home presentation here at Bucks County Surgical Suites in conjunction with our fine doctors from Bucks County Orthopedic Specialists. My name is Joe Fuchs. I am the administrator for the Surgery Center behind you. We are very excited to have you here this evening, and we're thanking you for coming out and spending some of your quality time with us. We know everybody has important things going on, and I think this is going to be very beneficial for you. With that being said, before any presentation, I always like to ask everybody, if you have a phone on you, please go ahead and minimize the sound, turn it off, whatever you have to do so it does not interrupt any of our speakers. We would appreciate that. Sitting next to me here are some of our finest, and these gentlemen, I'm going to start down the other end. Dr. Boylan, I still will start with Dr. Vicorn. Dr. Boylan is ortho and sports, obviously all of these folks from Bucks County Orthopedic Specialists. He went to medical school at Jefferson Medical College, residency at Montefiore, and fellowship at the University of Utah. And then next to him we have Joshua Steer. Dr. Steer studied at Creighton University and Loyola University of Chicago. His residency was completed at the Hospital of University of Pennsylvania, and his fellowship at Stanford University. Next to Dr. Steer, we have Dr. Burrows, also an orthopedic joint surgeon. Everybody here specializes in orthopedic joint surgery, that's why you're here. He graduated from Temple University. Residency was also at Temple University and his University of Pennsylvania for his fellowship. So thank you all for being here. Lastly, before we get to Dr. Vicorn, who is going to take us into the clinical aspects of the surgery, I would like to show you a brief video, and this is pretty remarkable. This is one of our patients who was here just Monday, had his total hip replaced. So I'm going to step out of the way and let you take a look.
This is day one after my surgery. Less than 24 hours. Less than 24 hours. And as you can see, I'm on a walker. Well, hold on a second. So this is less than 24 hours after, sorry, I got to put this on the camera, after surgery. And well, I'm on a cane, you don't want to forget the cane. So you have the right physical therapy before you get your hip surgery. You can do the cha-cha. So, before, seriously, yeah, it's an 8-inch incision right here. This is anterior. I didn't get it done at Rockman because I didn't want to waste the gas. Right here, at the surgical center, yeah, this is posterior, right? Anterior over here. It's up to you, Mike. Good luck.
It's up to you, Mike. Good luck. So he's egging on one of his best friends who wants to go to Rothman. So he sent him this video, and this was just Monday, which is remarkable. I do the preoperative teaching here at the center. I'm your nurse liaison at the time, so we'll bring you in, do that preoperative teaching. His thought about doing that. Any kind of strength preparation ahead of time, muscle building, physical therapy ahead of time does really help post-operatively. So we cover all of that while you're here. But I thought it was pretty funny. And he did mention the word anterior versus posterior. Our docs will talk about that as well. He did have a posterior surgery, not anterior, which he corrected. But I think pretty remarkable, isn't it? One day post-op and he's doing the cha-cha. I mean, this is, I don't know. I haven't had surgery, but I can't do the cha-cha. But anyway, so moving on. What we're going to do is, we met the surgeons. I'll introduce you to Dr. Vicorn here in a second. We're going to understand osteoarthritis. It's really the most common diagnosis that you're going to hear when you need a joint replaced is osteoarthritis. Obviously, the Heal at Home difference. This is something that we specialize in here. As you can see from our video there, he was sent home immediately after surgery, and he's doing the cha-cha the next day. And really, I gotta say, all the results are not the same. However, I will say that the majority of our patients really are experiencing the same thing. Absolutely amazed at how their experience goes and what they're doing in the week or 2 weeks afterwards. So we'll touch on that. We're very fortunate to have Roger Jones, who is one of our first patients after we started the surgery center here. He's going to give you his testimonial of his experience and how everything went. I'm sorry I'm blocking you folks here. And then we're going to answer some questions. So if you have any questions, we'll open up to some question and answers at the end of the session. And then we'll do a tour of the center. And I always tell everybody this is not a big facility. This is a nickel tour. You will be in and out before you know it. We're 8,000 square feet. And that's one of the things that I love about this center is you're in the front door, you get done what you need to get done. There's no other hoops to jump through. You're out the back door, and it's not that much longer. Typically our patients are about 5 hours, 4.5 hours to 5 hours from the time they walk in the front door to the time they walk out the back door. They're not rolling out in a wheelchair, they're walking out to their car, which is amazing. So without any further ado, you're here to see, our surgeons, not me. So Dr. Vicorn, he's obviously specializes in total joints as well. Graduated with his MD from Dartmouth College, residency from Duke, and his fellowship from Harvard. And I'm going to hand over the presentation to Dr. Vicorn.
Thanks, Joe. So, okay, so I'm going to make everyone a promise that in 20 minutes from now, you're going to know something that none of your friends know, which is about same-day joint replacement surgery, because most people don't know much about this. And the one thing that it's not included in this slide, so I want to make sure everyone understands. So the same-day total joint replacement surgery has two components to it. The surgeons, we are members of Bucks County Orthopedic Specialists, the orthopedic practice, and the facility is Bucks County Surgical Suites, which is ambulatory surgery center. And what's special about that is it's a freestanding location for joint replacement as opposed to a hospital-based surgery. So that's sort of the context that's very important to understand, and everything that we're going to talk about tonight in the context of that program. So the first thing to understand is many people ask, what is arthritis fundamentally? Joint replacement is done for arthritis. So arthritis is wear and tear of the joints that causes thinning of the cartilage, and when the cartilage is thinned down to where it's bone rubbing on bone, the nerves are very irritated and it's extremely painful. And there's really no way to put new cartilage in, so that's why people end up having joint replacement. And if I had a dime for every time somebody said, well, how do you put the new cartilage in? And I say, well, George Bush just had bilateral knee replacements. He knows every person in the whole world. I mean, he has tons of money. If there were a way to put new cartilage in so he didn't have to have it, I guarantee George Bush wouldn't have had knee replacements. But I saw him speak, and he's so happy with the results. So you see on the right, when the cartilage is worn out, there's no space, and then the bone is rubbing on bone, it's very painful. So this x-ray demonstrates the arthritis. So this is the left hip, because x-rays are, the convention is you're facing the person when you read the x-ray, and you see space here between the ball and the socket, and on the right side, there's no space. So that's bone-on-bone arthritis, and I suspect the person that matched this x-ray is probably in agonizing pain with every step they take. And here is extremely severe knee arthritis. Again, on the left, space between the bones, that's the space for the cartilage, which you don't see on the x-ray, and on the right side, complete 100% bone-on-bone. And the screws were left over from an old anterior cruciate ligament repair, which is probably how the arthritis got started because of the injuries that occurred with that, or the damage that occurred with that injury. So initially for arthritis, we try what's called conservative treatment. So we don't just go straight to surgery as the very first thing. For those who are overweight, weight management's beneficial. Exercise is actually beneficial. It's important to keep the joints moving so they don't get stiff and strong. And anti-inflammatories and Tylenol can be beneficial. If those don't work, sort of the next step up can be injections like cortisone or lubricating shots, which I would say the effectiveness is dependent on how severe the arthritis is. So the two x-rays I showed, those people, I'm guessing, would probably not get a lot of mileage out of shots. If a patient sitting in front of me insisted on a shot, I mean, I certainly wouldn't refuse to do it, but I would be skeptical that they'd get a lot of relief when it was that bad. So the surgical treatment, if the non-surgical treatments aren't working, is the replacement surgery, which is what we're here to talk about. So this depicts a hip replacement, which is over here, and this depicts a knee replacement. And actually there's some models floating around, and some real ones here and there that show that. So hip replacement in the United States is growing as a whole, growing tremendously, as well as among our practice. Dr. Steer just joined our group because of the increasing volume of replacement surgery being done in our country as a whole, with the population age that's getting to that kind of age. And we've had an extremely successful, by which I mean medically successful, joint replacement program at Bucks County Orthopedic Specialists with extremely low complication rates, and we have a number of different distinctions that have been awarded, I guess you might say, to the program because of our successful low complication rates that we have. And that's probably because of how intimately we are involved with our patients' care in this community setting, as opposed to disconnected from the patient's care, which is not a good, safe way to have surgery. So what's an interesting fact is that the length that people have required to stay in the hospital has been really going down over the years as advancements have occurred with surgical techniques, anesthesia techniques, pre-surgery preparedness, a variety of different things. And you can see over the past 5 to 7 years, the length of stay in a hospital setting just going down and down and down. And people just don't need to stay that long. And I mean, virtually nobody that has a single replacement goes to a nursing home. These are the majority of people just going home to their house. So if you look here, okay, here we are, 2018, 2019, you're having a length of stay for a hospital-based surgery that's hardly more than a single day, meaning we're going home the next morning. So what has naturally followed is the ability to conduct a safe surgery where people go home the very same day, which is what we're talking about. And which is a wonderful way of having a surgery, and a way that if my own family member were having it, I would want them to do it that way without any question. So basically, the program, this Heal at Home program, is the program of being able to have surgery and go home the same day. And involves basically using minimally invasive surgical techniques so that you can see people bearing full weight with very tolerable levels of pain. And really the benefit is the safety of going straight home. So here's a question: who knows why would it be safer, actually, safer to go home the very same day as the surgery?
Infections in the hospital.
Exactly, right? So they said, you know, that if you have a child in daycare, and the daycare, you go in there, you get sick in 2 seconds, but you don't get sick if you walk by on the sidewalk. I mean, if you're not in there, you're not going to get sick because you're not exposed to other people who are sick. And that's why, if my own family member were having this is exactly what I would want for them. And then medical issues predominate, but it actually happens to be much more cost-effective and cost-saving way to have a surgery like this. So we started doing go home the same day replacement surgeries in 2017, and it has been exponentially increasing. Studies predict in our country that about half of the replacements are going to be done in a go home the same day fashion within 5 years. I think that's a gross underestimate. So for example, my personal experience this week, out of 9 surgeries, 1 was a revision surgery. That would not be appropriate for going home the same day. Of the remaining 8, 6 were go home the same day. 6 out of 8 people. And I project that will continue a very significant increase. So what makes this special is that, and why we are here, is that we're talking about now not just go home the same day from a hospital setting, but go home the same day in a freestanding location, which takes that safety of the potential lowering of infection rate to a very, very significant increase in safety. So what the data show is that the infection risk in a freestanding location is probably about 1/10 of what it would be in a comparable hospital venue for surgery. There are other benefits. If you look on the internet, for example, the patients that have had surgery here, a lot of them have commented on the fact that they just felt better cared for because there are fewer distractions. There's no emergency room. The anesthesiologist isn't going to a labor or a cardiac surgery or something like that. There was one particular patient who had a previous surgery in a hospital setting, the second surgery here, and said the first surgery they told the nurse they had high pain, and they said, we'll call the anesthesia. Oh, they're tied up with something else, and the person was sitting there in pain for half an hour. And here, this person wrote on their little review on the internet that they called and said to the nurse, oh, I have too much pain. And the anesthesiologist was like, 5 seconds. They were right there. You'll see. There's nowhere else for them to be. So when patients are considering a replacement surgery, we identify, all of us do these replacement surgeries, identify those patients who might be a good candidate for go home the same day, which is primarily based on medical criteria. Making sure they have someone who can be with them at home. Somebody should not have a same-day surgery and go home by themselves. But they could be a friend. There are single people who have had surgery, go home the same day, and they have been very successful with a friend staying with them. So it's not like they have to be a medical person. And then we find it very beneficial for a visit to the center here to kind of alleviate concerns, ask questions, etc. There's one other thing I want to back up. I kind of glossed over this. This program that we have here is extremely unique in Pennsylvania. In Pennsylvania, Pennsylvania is kind of a conservative state. It's not like the Midwest or Texas or Florida, where it's kind of very freewheeling. In Pennsylvania, the state has to approve a facility to do go home the same day surgery. And there's an extremely rigorous process by which they do that, whereby they assess the safety of the surgeries the surgeons have conducted in a hospital setting at great detail to be sure that they've done this in a hospital setting before doing it in a freestanding location. And there are only 4 centers in the state that are approved to do this freestanding location. And we're one of the very pioneering centers in that. And our volume, I would not be surprised if actually our volume is probably the highest of the 4 centers. So this is not something, for example, this guy is talking about, taunting his friend. This is very unique to us. Oops. Okay, so basically we start in the office and we identify patients that might be a good candidate. When we do, and the person says that they would like to have the surgery at the Bucks County Surgical Suites, which is this, then we start putting them in contact with the center so that they will have a visit to meet and discuss the program with Joe on how to prepare. They will see if patients see their family doctor for pre-surgery medical clearances. And basically we start patients walking an hour after surgery. I mean, less maybe. The surgeries are done under spinal anesthetic where the legs are numbed. You're not on a breathing machine. There's no throwing up and all that kind of stuff. As soon as the numbing wears off, you are up walking on it full weight. We do therapy with a physical therapist on site to make sure people achieve their goals. We have not had a patient since we started, not a single one, not achieve the goals of being able to go home. And then when people are discharged, typically 2 hours, 3 hours after surgery, they're met at the home by physical therapist and a nurse, registered nurse in your house. And then again the next day. It's part of our protocol that we set up with the state that we all found to be an excellent safety measure. And then from those first 2 visits, thereafter you go to outpatient physical therapy. Basically, the advantages are, and we, of course, patients ask a lot, do you still do hospital-based surgeries? Of course we do hospital-based surgeries. And when we do, we still use less invasive techniques. But basically, the venue is what makes it quite special. And that safety of a freestanding center where we don't do any infection cases. There are nobody in the next room has MRSA. And you're going to be kind of at risk of getting exposed to that. The surgical techniques, I guess it goes without saying, they're very minimally invasive surgery techniques. You wouldn't see somebody walking an hour after surgery if they weren't. And our safety profile has been really exceptional. We have, in joint replacement, there's something called readmission. Readmission is a patient goes home, has to come back to the hospital for some reason to be readmitted for a complication. The nationwide readmission rate after total joint replacement in a hospital-based venue is something like 4.6%. Our rate for our hospital-based surgeries is lower than that. Our rate for the freestanding patients, you could almost contion a higher rate because you say, well, that maybe they didn't thrive while they were at home, but it's actually 0%. And that's one of the reasons why the state almost considers us like their best center. And a center, they asked a few months ago that there was a center in York that wanted to try to do this kind of thing, but they didn't feel like they were quite where they needed to be. You know, hey, would you guys be willing to coach them a little bit about what you're doing? So a lot of people ask one particular question that's very common in the office, which is, do you do the front incision? And the front incision is becoming a bit passé. There was some initial interest that it would be potentially a faster recovery, but what the vast majority of the studies are showing is a higher complication rate. And it's really kind of quite barbaric, because when you have to put the prosthesis in the front, the hip doesn't bend this direction to facilitate placement of the pin portion of the surgery. So you have to use this, this is an actual device. This isn't sort of like, this is truly like, if you open our orthopedic journals, this is an advertisement, and it's a, you know, a hook that goes under the bone to lift it out of the body so you can put the pin in. That is not less invasive. That's more invasive. And that's why studies show actually a higher rate of failure, but yet it's still, a lot of people market that that's less invasive. So
Higher infection rate.
And higher infection rate and higher nerve injury rate.
And light discrepancy.
Yeah. So anyway, we've had very successful patients. I think those are the medical aspects. I'll turn it back over to Joe, and then all four of us will be available for question and answer.
Thank you. Thanks, John.
Thank you.
I saw some of your faces when we were showing that picture. There was some laughing and there was some, there was horror out there, so we're not doing that here, so nice job. Thank you, Dr. Vicor. You know, some of the best ways to see what you're walking into is to look at the review. Everybody, you know, people are very free to give reviews. We have some great Google reviews. I would encourage everyone, I do this when I do the teaching for our patients. Go to Google, read the reviews. These are people that were in your seats. They had, you know, either needed a total hip or a total knee, whatever it is, and they came to our center and had excellent results. I would encourage you all to go read their results and their posts, because for me to explain to you how their procedures went and how their experience went, it's not the same. So with that being said, I do have a few up here for you. I'm going to leave this up here as Roger comes up, but I'm going to introduce Roger Jones. Roger Jones had a total hip replacement done, right? Total knee replacement. And what month? Was that February? January. It was even earlier. So January of 2019. So Roger is really one of our first patients that was here at the center. We started in December of 2018 doing total joint replacement surgery here, and worked with the state just like Dr. Vicor explained, and went through this very rigorous you know, program with the state. And I have to say, you know, as Dr. Vicor mentioned, we do work very closely with the state for multiple different reasons, whether it's helping another center, you know, start their total joint program. We're actually working with opening up outpatient surgery for total shoulder surgeries. Try saying that real quick. Okay. But hopefully that's coming down the road as well in the near future. So we're working with the state to get that going. So we're very excited with the advancements that we're making. But without further ado, I want to bring up Roger Jones, total knee replacement from January. Thank you, Roger.
Thank you, Jim.
Thank you for being here.
Thank you. Well, as Joe stated, my operation was actually over a year ago, so I took the time today to sort of break down my story. And a lot of the things that you've heard here today is exactly what I did, what had happened to me. So I'll go through this, so bear with me, give me a few minutes. So about 10 years ago, I had a meniscus repair on my left knee. It was my inside left knee. After the procedure was done, everything was fine for several years. However, the pain started to come back slowly as I was exercising and doing things around the house. So like a typical human being, I ignored the pain and just lived with it for quite a while. This was a huge mistake on my part, so all of you think about that. I went back to my original doctor back in July of 2018 for a review of my pain. The doctor said I had developed arthritis in my knee joint, and I was given a shot of cortisone and went on my way. The shot did zippo, nothing for me. So I continued living with the pain, which here again was stupid with me. So I felt that back in November of 2018, that enough was enough, and it was time for me to get a second opinion. So through a friend of mine at work, I learned about the Bucks County orthopedic specialist here in Doylestown. And then he had recommended that I visit Dr. McCorn. He said he had some work done with him and he was very happy with the results. So I contacted the office and made my first visit with Dr. McCorn on Thursday, December the 13th, 2018. During my visit, the x-rays were taken. I met with Dr. McCorn for the review. The prognosis that the doctor told me is I had bone on bone on my left knee and a replacement was required. So the topic of heal at home, as you've heard here today, came up, that I'd be an excellent candidate to do that. Have the procedure done via outpatient here at the Bucks County Surgical Suites in Warrenton. Brand new facility is what it was. So I said the idea intrigued me, so I said, sure, why not, yes. So on December 31st, 2018, New Year's Eve, I met with Joe, who's the administrator here at Bucks County Surgical Suites. We met briefly, and Joe went through everything that I was going to be done. A little bit of history with Joe. I met Joe through mutual association in the fire service. Joe ran with Warrington Fire Company and me with Percy, so we sort of hit it off a little bit on some of the fire stories. So as I said, Joe spent about an hour with me. He gave me a tour. He reviewed what I had to expect and what would happen during my time here. I was surprised to find out that I'd be the first person to have the knee replaced here at the facility. Dr. McCorn at that time had completed 10 hip replacements, and I'd be the first knee. I felt a little bit like a caged guinea pig at first, being the first one. However, my confidence was very high, and I was really impressed with everything that I saw, and was reassured that the operation would be a success. So my procedure was scheduled for Monday, January 7th, 2019. I arrived here at the facility at 6:30 in the morning with my wife Patty driving me, and I was prepped for the operation. I was amazed to find out that the focus of the morning was on little old me. I was like the only guy here. I had this whole facility to myself and was surrounded by and accompanied by close to 10 people watching me. It was like amazing. One of which was a lady from the Pennsylvania Department of Health who oversaw the operation. She was there for the certification procedure. So I was in the operating room by 8 a.m. and I was out by 9:30. Once the anesthesia wore off, as the doctor had said, the numbness, I'd walk roughly 200 steps, which I did with my walker, and do 1 or 2 steps on the simulated step that they have in here for me, and then I was able to go home. So travel between Warrington and Percy is roughly 35 minutes by car. We left Warrington here at 10:30 in the morning, and I was home at 11 a.m. And meeting us at the house was the visiting nurse and physical therapist who set me up for the balance of the day, and I would return, and they would return the next day to check me out. So my physical therapy started on Wednesday, January the 9th, and I was on the full road to recovery. In a summary, I'll say this. This is one of the best experiences I've ever had to go through regarding any operation I've ever had. The people, the experience, Dr. McCorn, and all the staff here at Bucks County Surgical Suites are definitely top of the line. If you're contemplating a knee or a hip replacement, this is the place to go and this is the way to go. The Real Heal at Home procedure worked wonders for me, and I'd be happy to speak to anybody after this. Thank you. Thank you.
How do you follow that? I mean, thank you, Roger. I do appreciate it. And I apologize. I did not realize that you were the first one. So just because we, a mutual relationship, both being firefighters, I reached out to Roger and asked him if he would be willing to speak to you folks, but I didn't even realize that he was the first. So it's been a busy year. We've had a great 2019 coming into 2020. We've done a lot of joint replacements, and we'd love to have all of you as well. If you need a surgery, a total joint replacement surgery, obviously, again, avoid the hospital, recover at home. You're in and out in about 5 hours, like 4.5 to 5 hours, as Roger mentioned. It is a personalized experience for everyone, and we are busier than we were in January, Roger, but I will tell you that our staff is still just as attentive. They are there for you, and I guarantee all of you, if you ever have a problem with anyone, you come see me and I'll take care of it. So it's one of the things I like about the center is it's a small, personalized feeling. I've been in other establishments, large establishments, and this is a different feeling. So excellent outcomes, enhanced safety as we talked about, very high patient satisfaction rate. Again, I encourage you to go to Google Bucks County Surgical Suites, take a look at the reviews, and then lower costs as we spoke. Finally, we'll go through some question and answers with our doctors here. We'll do a brief tour. As I mentioned, it's a quick tour. We are literally 8,000 square feet, so we'll have you come in the front door here. We'll take you into our recovery room, which is, Roger, I mean, you were there for the majority of the time, other than the 45 minutes to an hour that you're in the operating room. You're spending the rest of the time in the recovery room. And then if anybody is interested, we will have folks in the lobby here that can make an appointment for you if you wish to make an appointment with one of our surgeons. So again, thank you for all being here. I want to thank the surgeons for being here to answer these questions. And without further ado, let's jump into some questions. Yes, sir.
If you happen to be covered by traditional Medicare insurance,
Yes.
they cover go home the same day replacement in 2020 in a hospital venue only. They cover total knee. Anybody with a Medicare Advantage or private insurance can have either hip or knee in either place. That's fine. A patient with traditional Medicare can have total knee replacement in a freestanding facility, but a patient who's covered under traditional Medicare, just a straight Medicare, not the Medicare Advantage, would have a hospital-based surgery, but it still could be a go home the same day hospital-based surgery potentially, but it would be hospital-based, and it would be predicated upon your approval of your cardiologist, and we would never do something that they, if they felt observation was needed, we would do it that way.
And if you don't mind, I'll elaborate on Dr. Vicorn's as well. The state has set up very strict guidelines for us to follow. So in addition to any kind of heart disease, any kind of medical history that you have, we look at it as a whole, not just that you're, the one incident that you had, but really based as a whole to see what your score would be, whether you would be allowed to come to a facility like this or not for an outpatient total joint replacement. I think this gentleman first. Okay, go ahead. Right here, Bruce.
Obviously, it varies from you are before the operation. The more fit you are before, the quicker you're going to get better, such as the gentleman that we saw in the video earlier. I tell most patients at 3 months, you're back to full activities. Now, what does that mean? Some patients will be back much sooner than that, but if you plan on 3 months, you shouldn't be disappointed. Patients that are playing golf are often back to the range at 4 to 6 weeks after the operation. Some other big issues, driving. Patients that have a left lower extremity joint replacement, assuming your car is not automatic, are often back to driving within a couple weeks. Might take a little longer on the right side to have good control of the muscles if you have to hit the brakes or make a quick maneuver while driving. But 3 months, for most pretty heavy physical activities, you'll be back to doing them. And many patients will be back to doing things sooner than that. So after the operation, we're usually prescribing therapy 2 to 3 times per week. And that's perfectly adequate for most patients. Some patients will often choose to do exercises in the days between on their own in a home exercise program. And most patients at the 4 to 6 week post-operative visit, we're talking about discontinuing physical therapy, and they've discontinued the use of all assistive devices, meaning no canes, no walkers. I encourage patients to use stairs. I think one of the things that we've all learned is we probably babied our patients too much in the past. And when I started doing joint replacements back in the 1990s, it wasn't uncommon for patients to be in the hospital for 2 weeks. They wouldn't get out of bed often for a couple days after the operation. We saw those patients, they didn't do well. They had more problems with pneumonia, they had more problems with blood clots, and they had more difficult recovery. And unfortunately, it took us a while to learn that rapid recovery is really the key, not to a good early outcome, but to a good total outcome. And now we encourage our patients to use the stairs at home. In fact, patients often say to me, "Doctor, do I need a first floor setup? Do I need to sleep on that recliner bed?" And I say, absolutely not. Part of your therapy is getting up, going up and down the stairs, doing the things you need to do on a day, from day one. From day one. Early on, you're not going to want to be going up and down the stairs several times a day. You'll do it in the morning and evening. But as you get stronger, you do it more and more each day and each week. That's a great question. So joint replacements are lasting much longer than we initially thought. Again, going back to the experiences we had in the 90s, we were telling patients 5, 10 years. The vast majority of total knee replacements are lasting 20 years or longer, and the vast majority of total hip replacements are lasting 30 years. So that doesn't mean they all last that long, but statistically, they're very durable, very long-lasting devices. Revision surgery still is considered a hospital-based procedure, and the reason is that each revision surgery is different. There are differing levels of complexity, but could it be done as an outpatient? Will it at some point? I believe so, but today it's still, for the vast majority of my patients, just an overnight stay in a hospital environment.
Thank you.
Yes. What's revision? Is it something
Sure. Revision means a redo of a knee replacement. So let's say someone had a knee replacement done in 1990. Right. And they have now worn it out or it's failed for some reason. That is a redo of a joint replacement. That's specifically what revision means.
Thank you. I'm going to go with Eileen here, for Dr. Steer.
I mean, this is, I think, one of the hardest questions we have in the office is kind of when is the right time? So there's a lot of people who have joints that have worn down, that are painful, and then the question is, when do you finally decide to do surgery? And that's different for everybody, and it depends what the activity level is, it depends on how severely affected your life is, and most people get to a point when they're signing up for surgery where they just kind of say they've had it, you know, similar to what you're saying, that you give up more and more activities as the years go by, as the months go by, and maybe giving up one activity here and there is not, you can live with it, but once you start giving up the things that are really important, whether it's playing tennis, playing with grandkids, playing golf, you know, walking long distances. Some people who work have higher demands. So that's a little bit different for everybody. You know, I think we all agree that if there are non-operative kind of ways to take care of problems that get you to a satisfactory level of comfort, then great. But those only work for so long. And so I think you're kind of right at kind of that point is, you know, is the arthritis and the pain severe enough that it's worth trying these other things, or is it finally time to say, let's just do the new joint and go on from there? I've had it, I'm ready, and then say, okay, you know, so long as they're healthy and they've done, if I can't think of anything other than surgery to help them, then I'll still say, let's get it done.
So I think that's changed quite a bit with everything you hear about people becoming addicted to narcotics and things like that. So the pain medication, as far as leaving post-operatively, a lot of patients get quite a bit of relief even that first night. And I'll warn some people that it's probably more painful the second day rather than it is the first day. They usually get a block by the anesthesiologist, which will help with post-operative pain overnight. The next day, the pain might be a little bit worse, but we usually recommend that you start taking some pain medication even when that block is working and you're not having much pain. And we're as happy as anybody to have you off the pain medication. So our goal isn't to have you keep taking pain medication. Many people don't tolerate pain medication. They become nauseous from it anyway. They don't like it. So we usually recommend that patients take Tylenol and a fairly good dose of Tylenol as long as they don't have any issues with taking Tylenol with their liver or anything, and taking that around the clock, and then adding pain medication as a supplement to Tylenol. And some people say Tylenol doesn't do anything for me. If you take a large enough dose of Tylenol, and we usually recommend about 500 to 650 milligrams every 4 hours or so, and you're taking that on a regular basis, you may not require as much pain medication. A lot of times we also recommend Celebrex, which is an anti-inflammatory or some sort of anti-inflammatory if you can take that as well. So we try to take other things on a regular basis, then we're adding the pain medication as we need. And I usually tell my patients, you're going to need the pain medication, at least for the first few days. The goal is maybe the first few days you take it on a regular basis. After the first few days, though, you're not looking at the clock. You're trying to kind of spread that out longer and longer. You know, I think the patients that are actually doing the best are the ones that come in at 2 weeks, you know, or thereabouts, and they have, you know, staples taken out if they've had staples put in, and they're off their pain medication. You know, the people that are off their pain medication sooner, I think, do better, or just as, I think they probably do a little bit better than people that are still kind of on the pain medication. So we're usually trying to get patients off of that as much as possible. And some people just don't tolerate any pain medication, and I think they do fine when they realize a couple days later and they just go to the Tylenol. And I will say that, maybe I shouldn't say, but I will say that if you ask me to manage post-operative patients' pain, I'll take the 75 or 80-year-old female over the 50-year-old gentleman any day. Sorry, guys. But I think part of the reason, and I can't tell you for sure, but I think part of the reason is the bone's probably denser. I think that you know, it probably makes a difference in that regard. But I think the younger patients, some of the younger patients, tend to have a little bit more pain at the beginning. They all end up in the same place at the end and do well. But I do think that it's you know, everybody's different, you know, when it comes to that.
Okay, yeah, so double knee replacement, for some patients, it's very appropriate. At this point in time, we're not doing double knee replacement as an outpatient. Those patients are still being asked to stay at the minimum overnight in the hospital. And in my experience, I tell patients double knee replacement is about 3 times harder than a single knee replacement. It's a lot more stress in your system. And some of those patients still do elect to have some more aggressive rehabilitation after an operation. If a patient has 2 joints that are equally bad, and they're really struggling with both, I think doing both on the same day is an appropriate option. Assume medically you are fit. If one joint is a lot worse than the other, I think you're probably better off considering doing them one at a time. There's a lot of thought that goes into that discussion. It's a very individualized decision based upon each patient's needs, maybe how long they can be off from work, what sort of support they have at home to help them, because bilateral knee replacement is a more challenging non-outpatient operation.
And would you say it's still 3 months?
Yeah, I don't find the recovery significantly longer for a bilateral knee replacement, meaning both done on the same day. But I will tell you, the first 2 weeks is much more challenging to you as a patient. It is a lot harder recovery, and I think it's a cliche, but you don't have a good leg to stand on. And you know, you're going to recover well and do well after having both knees done, but you really have to be prepared for a more challenging set of circumstances in that first couple weeks right afterwards.
a lot of people have a huge amount of anxiety about the potential for the post-surgery pain, and it's come so far that, you know, the people, I mentioned this week, you know, number of people, outpatient surgery in particular here, of the people on Monday, for example, there are 5 people, all 5 people, full flight of stairs here before they went home within 2 hours after surgery. They're not in ag.
Nerve block.
But this is a phenomenon for, the nerve block is not super dense pain control. I mean, I think it helps. So think of it like this. If you go to war and there are machine guns and whatnot, you have that super loud sound. You come back and your ears are ringing because of the stimulation. If you go to a rock concert, you come home from the rock concert, ears are ringing in the car. If you wore earplugs in a rock concert and they took them out and you got in your car and drove home, you probably wouldn't have ringing in your ears. And the reason is that our nerves have sort of a threshold that if you exceed that threshold, it almost develops a life of its own, you might say, or kind of persistent. And so one of the major advances that has facilitated outpatient replacement surgery is the idea of a preemptive pain control. So blocking the pain receptors even before the stimulus of the pain is appreciated by the brain. It's a medication taken even before the surgery starts. The nerve block, if the nerve block may not completely eliminate the pain, but it's like wearing the earplugs to the rock concert. It's not so loud that it's intolerable. And so it's unreasonable to expect that there's not going to be some pain with the replacement, but I would not at all describe it as a severe level. And if you read on the, for example, like Joe said, Google, you can read people wrote in their experiences about having a replacement, and the vast majority of people said the pain was not as bad as they feared it would be. And now that being said, we do use pain medicine, even pain medicines like Percocet and that kind of thing. It's just we're combining them with other medicines that have a synergistic effect that dramatically reduce the amount of reliance on the narcotic type of pain medicines. And I have actually had a few patients who, one patient had a personal history of substance abuse, one patient had a family member who has a substance abuse history, and said they wanted 0 pain medicines, do not give me a narcotic, 0 narcotic, don't even give me a prescription. And they both had a totally successful replacement without a single narcotic pain pill the whole time.
That makes me feel better.
I saw the deep, sigh of relief. Okay, thank you, Dr. Whitecorn.
It depends a lot on pain level. So if the arthritis is truly just within the inside part, there are opportunities to do a partial knee replacement. If patients, a lot of patients can get pain on the outside part of the knee, and if patients have a significant amount of pain on the outside part, even if we don't see it on the x-ray, that's an indication that something's going on. Arthritis is part mechanical wear, but there's a biologic component to it too, and so if people have a lot of pain on the outside part, then I tend to recommend for a total knee replacement. I always tend to reserve, if I do sign up someone for a partial knee replacement, I will say, if we get in there and it looks really bad, then we want to have the option to do the total. But certainly if the arthritis is only on the inside part and that's where the pain is, then certainly a partial replacement can be a good option. So the studies have shown it doesn't last quite as long, and I think that's because the size of the implant is smaller, and so it has, just like a dental implant may come loose if you eat something hard, it can come loose, and that's usually, that's one way it doesn't last as long. The other is sometimes people end up getting arthritis on the other side anyway, and so those are kind of the 2 main reasons why they may get converted to a total knee replacement. So all 4 of us do use the next gen knee. There are some subtle variations in the base plate and stuff, but for the most part, we all use the Zimmer next gen. The reason, there are different makes and models that have, the Zimmer next gen There was a study published in The Lancet in 2019 that showed in an international registry that it had among the highest longevity at 20 years, which is why I choose to use it, and I think why we all... Yeah, it's tied with another one for being the best, and so it's got a long, durable track record. I've worked with surgeons who, they don't use implants that are less than 10 years old because all the major recalls happen within 10 years. And so something that's been on the market, it's got an established track record, I think it's important if you want a knee that's going to last 20 or plus years. From a technical standpoint, the steps are all about the same. In terms of getting the knee implant to fit onto the knee. But that being said, the knee is both bone and soft tissue, and so you keep a lot of the ligaments and the tendons around the knee. And depending on how long people have been living with arthritis, the ligaments may be tight here, not tight there, they may be a little bit looser here. So one of the benefits of doing the knee replacements the way we do it is we can kind of custom match the tightness of the implants. The implants come in different sizes, so we can shape it to the correct size of the bone. And depending on how the soft tissues are behaving, we can kind of tinker and make sure it's balanced, both when the knee's straight and when it's bent, so it's not loose on the inside part and tight on the outside part, because that wouldn't be very comfortable to walk on. So the technical steps of A, B, C, D are about the same, but then there's a lot of room for kind of fine-tuning it so that it functions as best as possible.
Thank you, Dr. Steer, and thank you for your question. Thank you all for your questions.